controversial question, but it's an absolutely common question, that we come across all the time. Active surveillance is not without its problems, not least of which is the anxiety of the man waiting for his next PSA result, waiting for his next MRI, and we know that active surveillance will carry on for a long period of time. A lot of men who are still, for example, in work, they will be looking just to have their cancer sorted out and not have to worry about the fact that they're living with a cancer. We know that we now have focal therapies available which cause very little harm. We have that good data, scientific data for that. And so therefore there is a shift occurring whereby we might be treating some of these patients who we know that they may not need treatment for at least 10 years, but because that man does not want such an empty follow-up and would not sit well with continuing active surveillance, that we could consider offering it to them. I've been in situations several times where they may have a family history. Their father may have died from advanced prostate cancer, and they do not want to fall into that category. So they do not want to sit there being told, I've got prostate cancer, but you're not doing anything about it.
There's an assumption that men on active surveillance are going to stay on active surveillance forever. That is, they'll never ever need to have treatment. But in fact, many of the studies show that at least 1/3 of patients on active surveillance eventually have a radical treatment of some kind or other. So active surveillance, not only do you have to have all the tests and biopsies and things of that nature, and maybe 2/3 of people do avoid a radical treatment, but still many will go on to have that. So if you can avoid that by having a simpler treatment earlier, I think there's a lot of value in that, and I think we should perhaps consider and offer it more frequently in those patients who are good candidates for it.